team took office with Dr. Godbole as president and Dr. Meenal Gadgil as secretary. And we wanted to do something more. At a team meeting, Dr. Katkade and Dr. Sonali Saraf floated the idea of journal club meetings. We put it to roll immediately, and in July of 2019, we had our first journal club meet at Thirani School Hall. It was a great success. Subsequently, we moved to Jupiter Hospital Fortune Hotel Hall, and till February 2020, we had our meets there. And then the pandemic struck and temporarily put a halt to our meetings, but not for long. We moved to the online platform, and again, they were very successful. We had participants from all over the country and could get speakers from all over the world. I am very happy to share that we have continued with these webinars uninterrupted and covered academic and non-academic topics of interest to all anesthesiologists. Our aim has always been to give a good platform to our local Thane members, and I'm very proud that out of the 100 members that we have, over 70 members have participated as speakers, moderators, organizers, and coordinators. Today is our 50th online session, and I dedicate it to all our supporters, and especially to our scientific committee of Dr. Nilima, Dr. Shamini, Dr. Sonali, Dr. Parna, and Dr. Amrapali, who come up with wonderful topics to help continue our professional development. Without further delay, I now request our charming secretary, Dr. Parna Thakkar, to start the scientific session.
Good evening, all. It indeed is a pleasure to be here on this platform. And as Manisha rightly said, that we have continued with our webinar sessions and the educational activities all throughout our journey. I'm privileged to welcome Dr. Deepa Kane and Dr. Jitendra Bapat for this webinar today evening. I welcome Deepa Kane Madam. Deepa Kane Madam, on a personal note, she's a very close friend and a very sweet person. When you meet her, you never feel that she's so senior to you, and she's very easygoing and a very lovely person to be with. Now let me introduce her. She is the professor at Department of Anesthesia at Sir G.S. Medical College, KM Hospital. She is ex-professor and head of Department of Cardiac Anesthesia, KM. She is ex-president ISM Mumbai. She is a GC member of SAM. She is the coordinator for the Regional Anesthesia Fellowship, MUHS. She is ethics committee member. She was ethics committee member from 2017 to 19. She is the reviewer of IJ Postgraduate Journal of Medicine, and she has experience of more than 30 years of teaching. Now, our next,
for your kind words.
Thank you, ma'am. Now, our next chairperson is Dr. Jitendra Bapat. He's a very close friend too, and he was my senior from JJ and also in Tata Memorial Hospital. His wife is a very close friend, and he is a very good teacher. And I remember my JJ days when he used to take lectures for us and share his knowledge with us. So let me introduce Dr. Jitendra Bapat. He has 28 years of experience. He's a consultant anesthesiologist at PD Hinduja Hospital, Mumbai. He's the past president, Indian Society of Anesthesia, Mumbai. Specialty training in rescue medicine from University of Hanover, Germany. Liver transplant anesthesia at University of Birmingham, UK. He's also trained in TEE at UK. He has additional qualifications of post-graduation diploma in medical legal system from Symbiosis University, Pune. He is MBA in hospital and health system management with Pilani. I welcome both our chairperson, Dr. Deepa Kane Madam and Dr. Jitendra Bapat. Yes. Manisha, you can take over.
Now I invite our moderator, Dr. Sonali Saraf, to start the session. Sonali is a very strong member of our Thane ISA team. She's a consultant at Jupiter Hospital with a special interest in solid organ transplant. She is also a wonderful artist. and she's held exhibitions in the city many a times. So over to Sonali now.
Yeah, thank you. Thank you for giving us this opportunity of presenting or renewing the journal club. We have fantastic, cases and heated debate at the end of it. So I would request all of you to please put yourselves on mute so that we can go uninterrupted. And if there are any mistakes in logging in and sharing our videos, so please bear with us. Our first speaker for the day is Dr. Nivedita Hundekari. So she is done her MD anesthesiology from Sion Hospital and is practicing for more than 25 years. She's a freelancing anesthesiologist, but presently heading the Department of Anesthesia at New Upasni Super Specialty Hospital, Mulund West. She has special interest in orthopedic anesthesia, regional anesthesia, and a lot of experience in doing high-risk obstetric cases. But today what she is going to share with us is an interesting case of a lost foreign body in esophagus. So over to you, Nivedita. Without much further this thing, let's start.
Yeah. Good evening, everyone. First of all, thanks to all my anesthesia colleagues and friends finding some time today evening to come join and listen to all of us. Thanks, Team Thane ISA, for inviting me to this webinar and letting me to share one of my interesting cases. So today's topic of my case presentation is management of anesthesia, foreign body in esophagus in an adult patient, which is conducted by me and my associate, Dr. Hetal Rathod. So anesthesia management for a patient with a foreign body in the esophagus requires careful consideration of several factors to ensure safe and effective airway management. Assessment, evaluate the patient's symptoms, medical history, physical examination to determine the severity of situation. Airway management, secure the airway with endotracheal tube intubation to prevent aspiration and ensure adequate ventilation and oxygenation. Choice of anesthesia, general anesthesia with muscle relaxation is preferred to facilitate removal of foreign body. Positioning, place the patient in head-up position to reduce the risk of aspiration. Monitoring, close monitoring of vital signs, especially oxygen saturation and cardiovascular stability. Removal of foreign body, coordinate with the surgical team to remove the foreign body under direct visualization. Post-operative care, close observation in the ICU or recovery room to manage the potential complication. So on 25th May, which is Saturday, late noon, male 45, weighing 110 kg, was posted for an emergency procedure for foreign body aspiration in the esophagus. I did see the patient in the casualty. He was obese, weighing around 110 kg, height around 160, so BMI around more than 40. He was NBN and he had chief complaints of throat pain and irritation since 4 days. He was alcoholic with no other surgical and medical surgical history and no comorbidities. On examination, his pulse, BP, saturation were normal. On auscultation, chest was clear, no murmur. On oral cavity examination, his mouth opening was less than 3 centimeter, thyromental distance less than 6 centimeter, MPC grade 3. You can see this picture that he had a thick and short neck. There's hardly any extension and no flexion at all. So I did send the blood investigation, routine blood investigation, HB, CBC, blood sugar, serum creatinine, SGOT, SGPT, viral markers, and X-ray chest ECG. As he was poor, we just did screening of 2D echo. X-ray chest ECG, 2D echo were normal. He did have a CT neck, which is done in the morning, which showed linear foreign body in the right retropharyngeal space, extending in the prevertebral space with associated moderate edema causing mild to moderate compromise in airway. It measures approximately 3.2 centimeter into 0.2 centimeter thickness. Subcutaneous emphysema is seen in the retropharyngeal region and left paralaryngeal region. Edema involves bilateral piriform fossa. So from his history and examination and this CT neck did show that he is potential candidate for a difficult intubation. So by that time the clearance was done, patient was wheeled into the pre-op recovery room where we did take the consent, surgical consent and anesthesia case consent was obtained. We did explain him that he might have awake fiber optic intubation where nasal tube might be placed post-operatively and he might require post-op ICU monitoring. I always feel that if any difficulty and emergency case you require help, please call for help. In our hospital, for certain cases and emergency procedures, we do have some protocols. They may not be the protocols, but some protocols for certain cases helps us in better coordination. So here the patient is nebulized with acetylene and Budocort, oxygen at 8 to 10 liters per minute, 10% lignocaine spray 5 times to the posterior pharyngeal wall, Otrivin nasal drops twice, 2% lignocaine jelly to the nasal airway, which help us to anesthetize the nasal airway, and we can assess the patency of the nostril also. Injection Dexa 8 milligram given IV, injection Derifylline IM 2 cc, aspiration prophylaxis, injection metclopropamide 10 milligram IV, injection Pantocid 40 milligram which is given IV, antibiotic injection Vitron 1 gram given IV, analgesia I did give injection paracetamol 1 gram in the recovery room, DVT pump. Whenever there is a difficult intubation, patient is very obese, I like to take a second IV line. By the same, during same time, my associate Dr. Hetal did prepare in the OT. Again, we have a fixed protocols for a difficult intubation checklist. Check oxygen cylinder, check suction machine with suction catheter attached, check workstation with circuits, inhalation agent, soda line, cardiac monitor with ETCO2, 2 pillows, head ring, 2 bed sheets for RAM position, 3 to 4 size airways, mask, LMA, smaller size endotracheal tube, lignocaine jelly, lignocaine goggles, spray, syringe, vial, laryngoscope blade, size 3, 4, Trupti blade, working, Buji stilate, videoscope, laryngoscope on and check. Here fiber optic bronchoscope was already kept ready, where did check with the suction and also the light sources attached and it is working. Stethoscope, ambu bag with tubing, ET tube stickings, micropore, gloves. Dr. Hetal did aspirate injection glyco 0.2 milligram, injection Vedas 1 milligram and fentanyl 100 microgram in the syringe and injection propofol in 20 ml syringe. By that time, the blood investigation came, which were normal. Surgeon was also in the OT. I always take, before you wheel the patient in the OT, just take 2 minutes that anesthetist, surgeons, OT staff and the technician are on the same page and they have prepared their side of the trolley. So when the patient was taken in the OT, we did ask the surgeon how much time approximately is going to take with that time in, time out. So he did say, she did say that she will take half an hour to 40 minutes. So as the patient was already on the oxygen 8 to 10 liters with nasal cannula, all the monitors attached, we did give the ramp position with the 2 pillows just below the shoulder and the upper part of the neck, head up 30 to 40 degrees. And I did check patient with the 100% oxygen with mask ventilation, where we did find little difficulty. And as we have explained the patient of the fiber optic intubation, we did anticipate it is a difficult intubation. We decided on table that we will go with the fiber optic bronchoscope. Surgeon requested us to put 6.5 small size endotracheal tube nasally. So after confirming with visually through fiber optic bronchoscope, auscultation, ETCO2, 6.5 centimeter nasal tube was fixed. ETCO2 was on and air entry bilaterally equal. Injection glycofentanyl midazolam, injection propofol and injection atracurum 50 milligram with sevoflurane with controlled ventilation done. Now, while the surgeon did cricopharyngoscope, it is edematous mucosa seen all over the posterior pharyngeal wall and right. Can you see this video? Hello.
Yes, we can.
Yes,
we
yes.
can see.
We can see. Yeah, we can see. No problem.
Mucosa seen all over the posterior pharyngeal wall, right arytenoid, right piriform fossa with no evidence of foreign body. We did have C-arm, so we did try to do with C-arm AP lateral view to see that whether we can locate any foreign body, but we could not see any foreign body in C-arm images also. So GI team was called and ogidoscopy was done. But this video was for the ogidoscopy, where everything was again edematous. So procedure was abandoned. Patient's relatives were informed And we did put RT16 and reverse patient with the injection myopyrrole at 2.5 milligram. As I have anticipated that the patient has a difficult intubation and significant oropharyngeal edema, I did put the patient on a T-piece with oxygen 8 to 10 liters, head up, and shifted to ICU for the post-op monitoring. Now here it was Saturday late evening, and there are three problems. As the surgeon had to give some definitive plan to the patient because foreign body was not removed. Second, the patient was not at all affording, so he did not know that he wants to do the further any procedure if anything is suggested by surgeon. So I was very clear till both of them they decide what they want to do with the further procedure. The tube will be in the place. So by next day, that is on Sunday afternoon, the surgeon decided that he would like to do the right neck exploration under GA, and relatives were okay with it. So I did again have the pre-op checkup that noon and advise continue oxygen with the TP 8 to 10 liters, propped position, proper suctioning of endotracheal tube. I did advise coagulation profile because it's going to be a neck exploration. Blood grouping cross-matching was done, and whether the blood is available or not, it is checked. High-risk consent and post-op ICU monitoring. But in the same night, the patient's relative said कि foreign body nikal gaya hoga, it must have migrated to a stomach. So they might be not willing for the surgery. So for that, this X-ray chest was taken, lateral neck. So whatever you see here, it is like query foreign body. So finally, the patient's relative agreed, and the patient was posted on Monday morning at 8 a.m. So again, all monitors are attached and proper endotracheal suction was done. I checked the air entry bilaterally equal, put the ETCO2 monitoring. It was showing a good graph. Patient was indulged with the patient was on Dexa 8 milligram BD. But here I started with injection hydrocod 100 milligram was given, injection glycofentanyl, midazolam, injection propofol, atracurum. With sevoflurane, controlled ventilation was done. Bilateral air entry was bilateral air entry, and all the patient was cardio stable. All the monitors were looking great. After patient was draped, patient was given head ring and shoulder. So after neck extension, around this all took around 20 minutes. There was sudden increase in the airway resistance, like airway pressure was going high and my ETCO2 was increasing. I did check if there is any kink of the tube and did check if there is a kink between the patient to the machine end. But everything was in proper place. I did have a query. It may be tube may be blocked. So I did request the surgeon, I would like to change the tube. So the C-arm was also in the OT. So it was very easy. I did put a tube exchanger, which I could see in C-arm image also. Remove that 6.5 tube under vision and again inserted a 7.5 endotracheal tube in place. It was the C-arm. I could see in C-arm images also. ETCO2 was also showing bilateral air entry, and then surgery restarted. Patient hemodynamically stable. So here, right neck exploration with horizontal neck dissection was done. There was a pulse discharge seen at the C2 level in the retropharyngeal area behind the superior pole. The foreign body has migrated through the posterior wall of the esophagus and it has entered into the paravertebral fascia where the infection was seen. So foreign body fishbone 3 centimeter into 3 centimeter, it was shown on the figure, S-shape, seen lodging in the paravertebral fascia and muscle. Fish take off its outside the esophageal lumen and 3/8 inside the wall of the esophagus with enormous swelling. Fishbone removed, 0.8 to 0.0 centimeter rent in the esophagus with parietal edges. Esophageal rent was sutured with 3/0 vicryl, followed by secondary covering of mucosa over it, drain, hemostasis, wound closure. Patient reversed with injection myopyrrole. Again, patient hemodynamically stable. And as again, patient had a difficult intubation, oropharyngeal edema. I have again put the patient on a T-piece with 8 to 10 liter head up and shifted to the ICU for a monitoring. With the joint decision of the intensivist surgeon, the patient was extubated after 6 hours because they were scared about the esophageal sutures giving give way and esophageal leak, which is one of the complications in this case. So I have to mention here, the way we plan for an intubation, you have to plan for your extubation also. So the things you have kept ready for the intubation, so extubation also have to plan as per guidelines. So after the next day, after 24 hours, drain was less than 10 cc, no soakage, drain removed. So post-op, patient was NBM for 3 weeks. RT formula was started 100 ml, 2 hourly, no cuffing, no straining, bed rest, propped up position, 45 degrees, no neck extension, ointment dressing, observed for drain, fever, neck swelling because there was chance of any esophageal leak. Treatment on discharge, patient was given injection for Magnex Fort, 1 gram IVBD for 7 days through RT feeds, Metrogel, Enzoflam, Predmet, tapering dose, tap pan 40, syrup cremafini. Patient was comfortable for 3 weeks, and then the barium swallow was done. And after 3 weeks, there was no leak, so all ended well. So if the time permits, I will just give a short brief that the foreign body in the esophagus. The common sites are tonsil, base of the tongue, pyriform fossa, esophagus. Etiology, children are more often affected. Loss of protective mechanism, use of upper dentures, loss of unconsciousness, epileptic seizures, deep sleep, alcohol intoxication, which is in my case. Carelessness, improper mastication, hasty eating, narrow esophageal lumen, esophageal stricture, carcinoma, psychotics. Site of lodgement, most common is the cricopharyngeal junction, the upper esophageal sphincter, where food enters the esophagus, then mid esophagus, lower esophageal strictures, diverticula. Signs, generally tenderness over the lower part of the neck. Indirect laryngoscope on examination might show you pulling of secretion in pyriform fossa and foreign body seen protruding in the esophageal opening. Symptom, history of initial choking, gagging, discomfort, pain just over the clavicle, dysphagia, drooling of saliva, respiratory distress, substernal epigastric pain. Investigation for the radiopaque, X-ray chase is must. You have to take X-ray chase from the neck, chest, and from in the abdomen, because if the foreign body gets migrated, it is better to you have all the view. And the lateral view is more important. Like in this X-ray, you can see this coin is circular in the AP view, but in the lateral view, you can see as a straight line. In lateral view, there are 3 or 4 things. You can see what type of the foreign body, what level of the foreign body, and number of the foreign bodies, and also where it is. You can see the air shadow here. So that is trachea, and this is esophagus. And the second X-ray, the same foreign body, if it is in trachea, it will be seen vertical in the AP and circular in a lateral view, because vocal cords are placed in such a way that the AP diameter is more than the horizontal direction. And for the radiolucent, fluoroscopy is done. So management, esophagoscopic removal, cervical esophagotomy, impacted sharp foreign bodies, like in our case, transthoracic esophagotomy. Complication, if there is a leak, then they can have aspiration pneumonitis, chemical pneumonitis, respiratory obstruction, neck abscesses, perforation of esophagus, tracheoesophageal ischiophila, and stricture of esophagus. So in take-home message, the role of anesthesiologist in an emergency high-risk difficult case is crucial. The key responsibilities are rapid assessment, mobilization, effective communication, creating protocols, team leadership, having adequate staff in the OT, good communication and coordination, which ensures unified approach, anesthesia plan, clear and meticulous anesthesia plan, and you have to have a backup plan if required. So these soft skills eventually saves out time and energy and helps to reduce stress on others and increases the safety of the patient. So good teamwork always ensures optimal patient outcomes. Thank you.
Thank you, Dr. Nivedita. A very good presentation and an excellent case, very well managed. Fish lovers, beware, I would say. Such a small fish bone and can do so much. One thing I wanted to say is, why couldn't that surgeon take a decision on the same day?
Because of the same financial issues of the patient. Patient was not willing for the neck exploration. So they had to wait. They said they want to wait. So that's why she could not do, she did not do in that day. And she also wanted to discuss what is the actual plan with her colleagues. Even I did speak to two of my anesthetists, my ENT colleagues, and even the gastroenterologists who had come to our hospital. If they had come across some case like this, but even they could not give any a proper decision ki what is to be done for the case. So the patient decided on the because of the financial issues, and they had queries, the foreign body may not be there, it must have gone down. So they had a discussion, and then they could do it on Monday.
Yeah. Dr. Bapat, would you like to comment?
Bapat sir, you are mute.
Sorry for that. Am I audible now?
Yes,
Yeah.
Sir.
The logistics in a small setup can be completely different, and in the big hospitals can be different. Like as Dr. Deepa Kane just now mentioned, that maybe a joint decision of a GI endoscopist and a ENT surgeon and an operative surgeon, all things, because if the CT scan was there with you people in hand, and if it had shown the foreign body with that retropharyngeal emphysema, it is very likely that your ENT person with just direct-scopy may not be able to view. The video clip what you showed, if I'm not wrong, at the end, it shows a very rugged margin where you can see that could have been the probable entry where it was impacted and from where it migrated. So yes, such a joint decision in a big hospital or a big setup can be achieved, but there are many other confounding factors like social status of the patient, affordability, and so on and so forth. My only one clinical query was the decision to insert the right tube after your first failure. Can be a little bit tricky in such patients because the esophagus is very fragile, and when you are trying to pass it without any monitoring, it can again perforate or it can get dislodged in a very it can just evade the esophagus. Sometimes we have seen when you do nasal intubations, while doing nasal intubations also you can create a false passage. So that was the only thing. Unless it was done with caution and with GI endoscopist under vision, and then you have confirmed. But otherwise, it's an excellent management case and very nicely done. So there is one question from the chat box, I suppose. Dr. Sonali.
yes. Dr. Shalu, Salahu, TP. Ma'am, have you given any airway regional blocks?
Me?
Yeah, for this case, while doing endoscopy or for maintenance of the endotracheal tube later?
In the ICU, you mean to say?
No, while doing the endoscopy, I think. While doing
was
the
under GA
bronchoscopy.
only. No, patient was under GA only.
No, during
No,
fiber optic
first time.
bronchoscopy, she must be asking.
First time.
Fiber optic,
Fiber
Generally,
optic.
we give transtracheal 2% lignocaine, but in this patient, the neck was very thick and short. But I did inject 2% diluted lignocaine in that injection port when it was at the cord level, when we were actually entering into the cords.
And did you have to give any sedation post-operatively to maintain the endotracheal tube and the TPs?
Actually, we generally give fentanyl, midazolam, or dextromid infusion, but this patient 6.5 nasal endotracheal tube he could tolerate very easily, and he did not require anything. As I think I explained him very well pre-op, you might have a tube nasally, so he was quite comfortable. Otherwise, we do start dextromid infusion or fentanyl midazolam infusion.
Okay.
Yeah, can I just add on some comment? Recently, we also used to use 10% xylocaine sprays intraorally and everything. But very recently, in Indian market, we have what is called as a metered aerosol devices, MAD. It is by Teleflex company, and we have started using that. It's brilliant device, and transnasally, you can beautifully anesthetize. We use 4% xylocaine, 3 cc's in each nostril. And because maybe the person who asked you about the regional anesthesia was more worried that when you did awake fiber optic, how did you take care when you introduced the fiber optic and when you intubated, how you prevented the gag, because sometimes as you go device, as you go, sometimes you can through bronchoscope, fiber optic, you can do that.
Yeah.
And because it is very crucial in such a case where the body can, while doing the intubation, if the patient bucks or something,
Yeah.
it can migrate the such a foreign body like
Foreign
a
body.
fish bowl, and it can get dislodged or it can rent. So maybe that was the in the mind of doctor who asked you, did you give regional blocks? But with that neck, what you showed,
Yeah. It's
and when
quite,
there is so much of a surgical emphysema,
yeah.
when the sonoanatomy is also completely distorted,
Yes, sir.
I doubt whether that would have been a possibility.
Okay, sir. Thank you.
Also, one more comment, post-operatively also you need to watch these patients
Yeah.
closely because already there's infection. So infection can spread and you can have mediastinitis and you can have sepsis. So temperature, basic things, tachycardia or chest discomfort or breathlessness, clinical signs, symptoms, whether the antibiotics
If
are
he was
working well.
comfortable, he did
Yeah,
not have
so
any
post-operative care is also very
more
important.
Yeah.
Follow-up is important. Ideally, a post-op imaging is also important to make sure that it's been taken care of.
Yes, madam. Yes.
Yeah, there is one comment in the chat box about the use of ultrasound for giving transtracheal lignocaine, especially in these necks. But I guess spray as you go works well as well when you are doing a fiber optic bronchoscopy. You can continue asking questions in the chat box if you have any, and we will get back to Dr. Nivedita.
Yeah.
But for now, ma'am, sir, should we move on to the next case?
Just one last comment. He asked about the USG for the transtracheal. Maybe he wants to know in any other obese case. If he's saying for any other obese case, it's a good idea to mark the space before you do the transtracheal, because by landmark technique, that's what he's trying to say. You may not be able to feel for the cricothyroid membrane. So it's a good idea to mark by USG if in an obese case. Yes.
Yeah.
Thank you, Dr. Nivedita, for a wonderful case.
Thank
Typical
you.
to get such a case on Saturday evening.
Yeah.
And we move on to our next speaker, Dr. Manjusha Gandla, who is going to present to us another interesting case of post-laparoscopy seizures. Dr. Manjusha Gandla is a director of Acuslim Wellness Clinic. She's done her MD anesthesiology from PM Hospital. And she has done her diploma in nutrition and diet planning and diploma in obesity management, both from the Gold Coast Academy at Australia. She's worked as a consultant anesthesiologist in the Regenesis Reliance Life Care Center of Assisted Reproduction, Endoscopy and Fetal Medicine for 5 years, from 2002 to 2007. She is presently working as a freelancing anesthesiologist with special interest in IVF, infertility cases, and high-risk obstetrics. Over to you, Dr. Manjusha.
Yeah, thank you, Madam Dr. Sonali. Hello, good evening all. I'm Dr. Manjusha Gandla. Thank you, ISA Thane branch, for giving me this opportunity to be part of this today's webinar. Thank you, Dr. Nilima and Dr. Manisha, for letting me present my case report today. So my case report is of post-laparoscopy PNES, which is psychogenic non-epileptic seizures. And the term psychogenic non-epileptic seizures, it says that those are not epileptic seizures, may instead be of psychogenic origin. At the same time, one should know that then the evaluation and management, that will be totally different from the similar appearing epileptic. Sorry, I can't see my thing. So that can, but both can coexist. And here the diagnosis is the gold standard by taking a proper history and video EEG, because there should be no epileptiform abnormalities seen on EEG in the pre-ictal or interictal period of that typical event. The incidence that has found out to be a recent systematic review in US incidence, which was 3.1 per 1 lakh with corresponding prevalence of 108.5 per 1 lakh. In ambulatory epileptic clinic, they found out like 5 to 10% of patients have this PNES rather than epilepsy. Between 20% to 40% of inpatients on epilepsy monitoring units have PNES. So the risk factor, it is seen in female sex between her teenage to her reproductive age, that is 15 to 35 years of age. There are psychiatric comorbidities like depression, anxiety, or post-traumatic stress syndrome. There is, suppose sometimes we find that there is history of sexual abuse during childhood, history of trauma, brain injury, surgical procedures in the past, or learning disabilities in childhood. So here my case is, she was 23 years old female who was a resident of Yemen, Aden. So it was like neither I could talk Arabic, nor she could understand English. So that was a big communication gap between us. So the history I could take via mobile translator. So I just could ask her basic history like fasting state, because she was for diagnostic laparoscopy under general anesthesia. Her diagnosis was primary infertility since she's 23 years old, but she was married for 7 years. So maybe like childhood marriage. But there was no significant medical or surgical history in this case. There was no past history of any allergy. Medication, she was on folic acid per day and vitamin D3 once a week. There was no specific personal history, no addiction. She was non-vegetarian. Her general condition, she was ASA grade 1, healthy, no pallor, lymphadenopathy, or thyroid swelling. Her vitals were normal. She was Malampati classification 1, free neck mobility, no loose or false teeth. RS-CVS was NAD. Her routine investigations, including X-ray and ECG, was normal. So pre-operatively consent was taken, starvation confirmed, IV line with 20 number vent flow was secured on left arm, and ringalactate was started. Injection pan, MSET, Taxim was given half an hour before surgery. So in operation theater, her basic monitoring, including induction of anesthesia, showed average normal values. Pre-operative oxygenated for 3 minutes. Intraop, her sedation was given with IV midazolam 2 milligram, 1421, and glycopyrrolate 0.2 milligram. She was induced with injection propofol, fentanyl, and confirmed ventilation. Injection succinylcholine 60 milligram was given, and she was intubated with 7 number Cortex cuff tube. Confirmed intubation by auscultation and EtCO2 graph. And then she was put on controlled ventilation on closed circuit, oxygen, nitrous, and isoflurane. Her bolus 20 milligram of injection atracurium was given. She was maintained on injection propofol, injection fentanyl, and intermittent inhalational isoflurane. Her induction, intubation, ventilation, everything was uneventful. Intraoperative, all vitals well maintained. And even surgical time was hardly 35 to 40 minutes, where chromoperturbation was done. Diagnostic laparoscopy otherwise was normal, including histoscopy, where hardly not 1 liter of saline was required. So she was reversed with injection atropine, neostigmine after complete recovery with obeying commands with good tone and reflexes. Patient was extubated. Recovery was uneventful and patient was shifted to recovery room. Patient's vital were normal in recovery room. For post-operative pain relief in OT, we had given her Tabloc and Zonac suppository per rectally was put. She started curling up when I had gone to see her after my paper writing. She started curling up. So I asked sister to add injection Dynapar in last 150 ml of ringalactate. After 20 minutes, patient had involuntary movements of hands first with facial twitches. That's how sister had explained me on phone, followed by leg jerks. So while reaching to hospital, back to hospital, I had that mind whether is it Dynapar reaction or is it tetany where patient has hypocalcemic things, or tonic-clonic convulsive movements. So I told sister, just stop Dynapar tip and take her to OT if I need to go ahead with any type of intervention or airway securing. So basically when she was taken in the OT, her vitals were normal. She did not respond to oral commands, but she was continuously maintaining her airway with good saturation on air, no tongue bite, no frothing from air. So nasal oxygen by prawns started, urinary catheterization was done. Bolus, thinking of Dynapar reaction, I had given hydrocot and Dexa, even started calcium gluconate side by. And here, if you see, I couldn't take a proper video because I was busy doing this. And here we can see the hands are fine now. She was moving her head and legs movement. So I had given injection mida. So what we can see now is after giving midazolam 1.5 grams slowly. So advanced management here started once she started getting those involuntary continuous jerky movements of all four limbs. So thinking of for my safety, I started giving her anti-epileptic dose of injection Levipil, 500 milligram, followed by 500 milligram bolus, where those jerks got diminished. Then again, she started getting those involuntary movements. So repeated bolus injection of midazolam 1 milligram, which again calmed her down. But again, after 10 minutes, those movements got repeated. So then I thought of giving injection propofol. So I gave her 30 milligram bolus, where she became, again, she calmed down, stopped jerking. So by that time, I took care of her IV line by putting a splint. And here we called for ambulance to transfer for hospital ICU. So throughout my ambulance journey, her vitals were normal, where the monitor was on, nasal oxygen was on. Those jerky movements got repeated every 15 minutes, but here now the severity was diminished. And so I continued in this case also, again, IV bolus of propofol throughout my ambulance. Then she was taken here in the ICU. Here, we can see that again the monitors they had attached before she gets another episode because they wanted to watch her. And here, this was IV line taken by me, and on the right side, they had collected all her blood profile, and even this side now she's giving those jerky movements of legs, hands, and head side to side movements. And then she's getting calmed down on her own, turning to one side again. So when she calmed down, we tried to wake her up, and there she was not responding. Here we tried to tap on her shoulder, but she couldn't respond to that. So here my differential diagnosis for epileptic seizures, it goes like psychogenic non-epileptic events, though we do find other things like panic attacks, syncopal attacks, or hypoglycemia, transient ischemic attacks, migraine, transient global amnesia, non-epileptic myoclonus, hemifacial spasm, or maybe tics and sleep disorders, which are generally seen in frontal lobe epilepsy. Also, hypnic jerks, narcolepsy, parasomnias, or REM sleep behavior disorder, or periodic limb movements. So paroxysmal movements disorders are relatively rare, but here some subtypes I would like to focus on, like paroxysmal kinesigenic dyskinesia, where those are short spells, last for some minutes and triggered by sudden movements. Paroxysmal non-kinesigenic dyskinesia, those are longer spells lasting hours, provoked usually by caffeine, alcohol intake, but not movements. Exercise-induced dyskinesia interwoven with exertion. Paroxysmal hypnogenic dyskinesia with brief nocturnal attacks considered as a form of nocturnal frontal lobe epilepsy or episodic ataxias. So these disorders, they have that choreoform movements characterized by arrhythmic, repetitive movements of various body portions with preserved awareness and full recollection. They are also commonly associated with superimposed dystonia characterized by twisting movements and abnormal postures. So here I have just given some summary like PKND and frontal lobe epilepsy. What happens? They are originally from brain. So these are actually treated with benzodiazepines. PKND where diazepam works beautiful, that improves the quality of their life. And frontal lobe is a proper epilepsy thing where the anti-epileptics work. So in my case, when we were seeing those generalized tonic-clonic movements and or syncopal, but here my diagnosis was more going towards pseudo seizures, as she was having eye movements, and here I have described it like those were asynchronous movements, variable from tonic-clonic type. There was no tongue bite at all, no froth from her mouth. Head movement side to side, pelvic thrust was there. It was of gradual onset. Here, Babinski sign was absent. There was no fanning of toes. Open and constricting movements where pupils were reacting to light. And these episodes stayed for a longer period. Here, so looking at her normal ECG tracing, they had given her injection haloperidol 5 milligram, where other vitals were absolutely normal in ICU as well, where the abdomen was soft, dressing was there, saturation well maintained, oxygen was on, and her ABG, blood electrolytes, sugars, ECG, LFT, RFT, PT, activated PT, CBC, urine, all these reports came normal. So in the evening, my consultant, she took a round where she found that patient was well sedated, stable. And here actually she had asked for neurological reference. So for nurses, the instructions were given to watch for any episode of same seizures, to monitor early urine output. She was kept NBM. The Levipil was continued till the diagnosis was made. Neurological reference, serum electrolytes and ABG was repeated, and GCS, the Glasgow Coma Scale monitoring was advised. So basically, Glasgow Coma Scale, it tells us about the decrease in consciousness and also any disruption happening in the nervous system function. So we come to know about central nervous system and PNS as well. So we check 3 categories here: eye response, like how awake and alert the patient is; motor response, that how well the brain is controlling the muscle movements; and verbal is how well certain brain abilities work. And GCAP is the pupil score, where here it was 0, both the pupils react to light. They generally subtract that pupil score. And so here my patient's eye response was 4, where she was closing and opening and looking in between. Then verbal response was 3rd, she was blabbering, and motor response was 5, where she was trying to move away when we try to wake her up. And so here it's quite shows the highest possible score, which is close 12 number. So we know that no neurological involvement, because since even EEG was normal. So here for the next day, when they found out that when she got up, she was absolutely fine with all her vitals normal, and neurologically also neurologists found her very stable. Actually, he wanted to send her LDH and total CPK, but EEG was showing absolutely normal alpha waves here, no lactic acidosis. She was stable vitally with good urine output, conscious, oriented, alert, and following commands. So as if nothing happened to her, she was absolutely fine. The neurological reference was Levipil to continue, because BD, because MRI brain plane that was not done due to financial constraints. So here patient was monitored throughout, and after 1 dose of haloperidol, which was 5 milligram, no any other similar effect was, the episode was seen till discharge. So here the diagnosis they made like primary infertility with very PNES. So what I started thinking back, that I had given so much of dosage of benzodiazepines, then I had given her anti-epileptics, then I tried giving her anesthetic propofol, but though she was not getting control with all those medicines. And when in the ICU, when they had given her haloperidol, which blocks dopamine D2 receptor, which is like antipsychotic action. So I knew that that is given for schizophrenia, where hallucination and delusion, they taken care of that symptoms. So only we know that decrease or increased dopamine conditions like Parkinson's or schizophrenia. But when the patient get diagnosed with the psychological non-epileptic seizures, it can be vexing for the patient. They present considerable diagnostic and therapeutic challenges, not only to neurologists, psychiatrists, but even if it happens post-operative, then even healthcare professionals like us, anesthesiologists. So broadly construed non-epileptic events, they are paroxysmal and arising from physiologic or psychogenic origin. So they closely resemble like epileptic seizures, but they are not caused by that excessive synchronous cortical EEG activity that defines epileptic seizures, nor they associated with concomitant epileptic form abnormalities on EEG. So practitioners generally tend to call it like pseudo seizures. But most of the time, then patient gets labeled that as if patient is faking or feigning the events, when in fact actually those events are involuntary behavior responses to underlying psychological trigger or stresses. So the previously what terms we used to say that, oh, patient became hysterical or functional. So nowadays nobody uses those terms in psychiatry also. So here, once the diagnosis is made, the treatment gets individualized. Supportive care should be initiated immediately. Patient need to follow up visits in neurology clinic in absence of identified psychopathology or psychiatric or neuropsychological evaluation. Pharmacotherapy, if required, if we know the underlying causes anxiety or post-traumatic stress disorder or any psychiatric condition that helps those patients. Psychotherapy like cognitive behavior therapy, which is the most effective treatment, they found out around 50% of reduction in those seizure frequency after giving CBT alone, or 60% reduction when it's combined with antidepressant. So this trial also noted considerable improvements in those patients with overall quality of their life, mood, and global functioning. So, so I only knew the schizophrenia is the indication when she was given haloperidol, but Tourette syndrome, several behavioral disorders in children, they do give this medicine off-label in cases like agitation associated with psychiatric disorder. In my case, acute mania. But one should know why every time they were checking ECG, because it has the risk of increased QTC interval prolongation or torsionist de pointes or sudden death also. So it is avoided in hypokalemia or hypomagnesemia or hypothyroidism or pre-existing cardiac anomalies. Now the agitation here also, while it was happening like this, because we could make out that if those are not seizures, then it can be the agitation. So pain was not the factor, the head trauma was not the condition here, no infective pathology, no encephalopathy or any environmental toxin, no metabolic derangement, because we had hardly used less than 1 liter of saline, no hypoxia, thyroid, or no any intoxication withdrawal. So this suggests more of those psychotic disorders. So in ICU protocol, they generally follow mild, moderate, severe type of agitation. Where my case suggests it's a little moderate type, where it was agitated but disruptive without danger. So midazolam was already given as a first choice of drug in the OT itself. So the alternative was haloperidol 5 to 10 milligrams. So they had given the low dose, I mean, very minimum low dose 5 milligram, because their protocol says start low and go slow. We had spoken to neurologists. He said that nowadays they do give injection dexmedetomidine also in the ICU for agitation patient more oftenly. So what I feel that what we see in those psychiatric illnesses or the conditions is just the tip of the iceberg. What lies beneath is the great psychological distress. So the prevalence of infertility related stress in India is quite high. It's around 92.71%, which is really very high. And so we started doing this HAT scale, where it tells us about anxiety and the depression score, where 0 to 7 is normal, 8 to 10 is borderline abnormal, and 11 to 21 is abnormal. So we do have our in-house psychologist, and this hospital anxiety and depression scale is composed of 14 questions, where 7 questions are for anxiety and 7 questions are given for depression, to assess like how much great they have, and helping clinicians identify patients who need this special psychiatric care. So what I feel like that when we find those score is that borderline, of course, that ahead of borderline goes to psychiatry evaluation. But those borderline cases, at least we can start tablet clonazepam, which is like mild dose for anxiety. Mouth dissolving is available 0.25. We can start 2 days prior the surgery. Alprazolam, everybody knows about it. And the patients who have such a history of seizures in past or panic attacks, they can be given clonazepam 0.25 milligram pre-op. Tablet magnesium sulfate 200 milligram BD is nowadays been given for even in pregnancy, because it gives you mind and muscle relaxation. Because they are still very anxious or very we can say that not depressed, but they are anxious about pregnancy once they conceive. Throughout pregnancy, they carry that anxiety throughout pregnancy. And tablet melatonin 3 milligram is generally given for those patients who have sleeping disorders or who are working for those multi-international companies where the sleep is been affected, night sleep especially. So there the melatonin 3 milligram is also given. So what my take home message is like protecting mental health at all cost is really important. So by presenting my case, I just wanted to put little light on care about rare cases like this. Thank you.
Thank you, Dr. Manjusha. That was a very good presentation and a very uncommon case, but which gives us a lot of stress. Can you hear me?
Yeah, only
Yeah.
the thing is,
Yeah. So,
it's good. Yes.
Dr. Deepak, we can't hear you. Are you speaking?
Manjusha?
Yeah, yeah, I can hear.
Manjusha, you can stop the screen sharing.
Yeah, I know.
We can see you
Stop
both
share.
and,
Yeah, so that's how I couldn't see. Yeah.
Deepa madam,
Madam,
Is she
I think she's logged out
lost
by
that?
mistake. Yeah.
Can someone call her or ask her to rejoin or something? By that time, may I comment upon the
Yes,
case?
sir. Yes,
Yeah.
I will
Yeah.
call her up. You please go ahead.
Yeah, Dr. Manjusha, excellent
Yes, sir.
case. It's a rare case to come across, and sometimes it's very conflicting, and you don't know what you are dealing with. And 2, 3 comments about your case, and please don't take it in me wrong. 2, 3 things I couldn't understand was you said the patient received 1421 milligrams, and then you switched over to a fentanyl. I don't know whether that's a usual practice in the private practice where
So
maybe
private practice.
maybe in a ward that is not available, so you gave 14. Another thing, it was a diagnostic laparohysteroscopy, and it's a short procedure. Why did you offer tab block? I don't know, because usually the port infiltrations with local anesthetic suffice. Third thing, Jonac suppository was put in, and still intravenous diclofenac was ordered post-operatively. So these are the only 3 things where we say that please don't give polypharmacy or don't exceed the stuff. There's one question by Dr. Tulsidas also, because he was also thinking, what was your drug for the tab block? How much total cc's and what strength you gave? Because this must be a tiny little girl, and whether it was a delayed manifestation of lust, that was the question by Dr. Tulsidas, which I'm just sharing with you. Because when you thought of all the possibilities of differential diagnosis in an epilepsy or seizures post-operatively, I think Dr. Deepa Khanna is back. Can she can start her comments?
yeah, I missed
Yeah.
a few things, but what I want to say is she's taken into consideration the differential diagnosis, all the electrolytes and the glucose, all that she has checked. That was good. And more important is you involved the neurologist. So call for help and call for expert is a very important part of our protocol. Even if you have a doubt that may be tonic-clonic, especially your first time you have not seen yourself, the nurse has told you about the convulsion that you involve the neurologist is a very good thing. Let the neurologist do the EEG, and then only be sure it's not a tonic-clonic convulsion. Though in your video we can see that it's not like a tonic-clonic convulsion, But if you have any doubt, to involve the specialist is a very good idea. And also that your holistic approach, that you're including mental health in the part of your protocol, because she does cases, I know infertility cases with a husband who's a gynecologist, and she's involving, she's making it more holistic by taking care of mental health even pre-operatively. You may have less complications in the perioperative period. And I do agree with Dr. Bapat about polypharmacy. We should try to avoid polypharmacy because Fortwin and fentanyl don't go together. Then Zonac, suppository with IV, you do one of the two. That would be a better idea. Thank you.
So,
I have some few comments to make. As you deal with more and more expatriates, we have to be very careful with the informed consent in these patients because something goes wrong and then the embassies are involved and then it's a lot of paperwork and things can go wrong. So especially when you're dealing with the expatriate patients, you have to be really careful. Another thing which I just wanted to share is that you have used the propofol as an induction agent, but just for the people who are participating, the when we use etomidate and not the propofol, the etomidate itself is known to give rise to myoclonic jerks, but it is also known to give rise to epileptiform seizures post-operatively. Incidentally, we had one case very recently and which we documented, and then we did the MRI also because patient could afford. And anytime you do MRI, you always pick up a post-ictal activity, and that's a hallmark that okay, that activity was a real seizure or the grand mal or whatever kind of epilepsy, because your diagnosis is by exclusion. You ruled out each and every possibility and a metabolic cause. And in an hysteroarthroscopy, another concern in my mind was there any embolic phenomenon? And you may not have the classical embolism, where you have a drop of EtCO2 and hypotension, but there could be a microemboli, especially when the gynec people either use the air to see a tubal patency. If they're using methylene blue, that's a different story. But
methylene blue was used.
but the trocar insertions, their venous things, they are very hyperemic. These primary infertility patients, they are on various protocols with hormone replacements, and I think the psychological load what you shared in your case goes more in hand of a psychogenic, because a girl who is married for 7 years, especially in the Gulf country, if she doesn't have the issue, attention-seeking behaviors and things are very common. I mean, I have worked in Gulf, so I know and I can correlate, but that goes hand in hand. But it's a nice case and nicely managed. And any other questions from the other participants, please feel free.
So another comment is psychogenic. Many a times we used to put a rubber catheter into the nostril, or you give the ether to smell and you see. But there are some cases, in spite of putting the rubber catheter, they would act as though nothing has happened. So, but if the patient moves to the nostril, you have really ruling out one thing which you have in mind. So that's also helpful. So that's a common thing we used to do in the past.
Dr. Manjusha, just this thing from you. You had a language barrier, right? Here.
Yes.
So you didn't have much information about her.
No. It was like just basic questions I could ask on mobile translator because before we took her in, I had enough time to ask major questions, and I auscultated and asked her husband, who was equally very young. He was also hardly 25 years old. So, and they both were looking very anxious since the new city, the new country, and it was everything new for them. So that's how I just could ask whether you have eaten anything and any any major medical thing in your childhood, but I couldn't get any of that type of history.
True.
You can
Did you give anything in writing to them about such an episode occurring after anesthesia, so that even in the subsequent if they undergo subsequent anesthetics, then somebody else is aware?
For our cases, actually, we do take the consent, informed consent form, as sir said. We explain them everything because generally I do all operative cases. This was like first time I got the diagnostic case, which was like could finish early. And so that's how I prepare. I have to give this Fortwin beforehand, and when the patient induction happen, then I switch over to fentanyl generally. So that was the one thing. And basically here, since it was not operated, we just could finish it fast. So that's how I thought that there nothing went wrong intraoperatively when everything was happening, everything. And this was like to my it was like surprise for me that suddenly she started jumping around. And but that's how I could manage her to my best. But then I knew that I have to shift her to ICU because she was impossible to manage by. Otherwise, those nowadays midazolam nasal spray also comes. So that also initially when nothing is available, we can just spray in the nose and the patient becomes calm and quiet. So that is also easily available because one of my patient who was on higher anti-epileptic dosage for the cesarean and she used to get aura every time. So I had asked her to get the spray and keep it in the OT. So if you feel like you're getting anxious and things like that, you can always take that nasal spray yourself. So yeah, so
So I
that
think
is.
Dr. Sonali is pointing towards we don't practice as a specialty that when the discharge card or the discharge summary is dictated, we don't make it a point to mention these things and to hand over to the patient. So in future, suppose such things are coming at the next anesthetist for the next, maybe she comes for the OM pickup later. He knows that such things have happened and it keeps him more well informed what it could be. And I myself was benefited like this, where the Borelli Anesthesia Association made it a point to hand over such discharge of a patient who received the scoline apnea, and he landed up. The patient's son landed up in our hospital for a adenoidectomy, and the lady said, "No, I want to speak to the anesthetist because I was told by the anesthetist from Borelli to speak and share that I was ventilated for 7 hours after the DNC." So I think she's referring to that as a specialty. We should take it to a point that something goes really something wrong. We should put it on paper and hand over it to a patient and patient relatives. So that will save or help in next management. Yeah.
Right.
Yeah, that's a very important point. Yeah.
Yeah, because in my clinic generally, because I'm the anesthesiologist, so I generally write when patient conceives and comes with the pregnancy paper, then it's always written about my anesthesia note mentioning that, oh, she got reaction of this or the things like that. So whatever happens during surgery, in os tightening or anything, any surgery, it's always written on the right side of our pregnancy paper so that we know that this was done and this how she had a lot of allergies also.
There's one question in the chat box. How did you document the consent? What language was it documented in?
It's in Hindi, English, and Marathi, all three languages, because our laparoscopy for her, because she was not our case, basically it was other consultant case. I had just gone like a freelancing anesthesiologist and just giving anesthesia. And so I didn't have, and I don't interfere like other surgeons or other doctors cases, like what you have taken the things. Only whatever is important anesthesia wise, I make a point that you take the consent. If hydrosalping's delinking going to be there, just we need to inform. I also go and talk to patient that this will be done in drop, so you should be aware of it, and the consent of the patient itself is required. So
but
that
for
is the
anesthesia, did you take any special consent or that was the question, the anesthesia consent?
For anesthesia consent, whatever is there on the paper, if I get to come across with any high risk or anything, then I write it. Otherwise, no, it's like general hospital consent, whatever for anesthesia has been taken, that is only done.
Manjusha, I think Dr. Sonali is asking because there was a communication barrier. You have to explain in the language the patient understands. Coming to
that consultant was talking in Arabic, sometimes some words she was talking, as Dr. Bapat also said, even he can speak Arabic, I guess.
So,
what is practiced, and for the benefit of all the attending people, I am sharing that in our hospital, what we practice, that we get official translators from the embassy. They're a little pricey, but they come down, they explain everything, what are our concerns, which are Hindi or English, to the patient. Patient understands, and he signs as a witness. So that's a good practice. I mean, little payment, 500 rupees or 2000 rupees goes to the official translator. The official translator from embassies are available, and in especially in a high risk cases, if you really anticipate, you can really call them, or you can phone a friend like me who can talk to the patient and understand. And I have done that in my own hospital. When the patient is being extubated, I'm at home, and on phone I have said, okay, now open your eyes, show your tongue, and they were very happy. So yeah.
I
Anyway,
think my consultant, she had done that before getting, because otherwise how anybody will, go for surgery like that. So she had done that homework and she has just told me that this is the case like this. And you can just ask on the mobile translator if you want to ask the other things, which I have checked. But then I don't believe in anybody's thing that unless until you ask yourself, you feel better. So, but otherwise, yes, she had done all that because she is attached to institute where I think the whole assessment is done by them.
So may I ask one question here?
So,
Regarding this consent, is it always essential that there should be a translator from the embassy? Or is it okay if we appoint somebody who knows the language and who acts as a translator between us and the patient?
no, in the court of law, the translator from the embassy is always valued more. You can have the another person who can understand the language. That's not a problem at all. But especially in an anticipated high risk perioperative where there's a more morbidity or mortality, we ask for the translator from embassy. Of course, any other person also who knows the language also can sign and say that he has used as a mediator and he explained all the risks to the patient and patient understood. That's also fine. But every time you that may not be handy and always available in the hospital setup.
Thank you, sir.
yeah. So, I just wanted to add that in our hospital, regularly we have translators. I'm not sure if they are from embassy, because no one has ever mentioned it, but translators are there. So, any translator is okay to sign the consent, but translator has to be there if the patient doesn't understand the language in which the consent is taken. So, that's by the law. Also, I wanted to ask her, okay, what is the logic? I didn't understand the logic of giving Fortwin first and then giving fentanyl.
Fentanyl is like for maintenance.
Discussed. I think, yeah, we should. It's already discussed. Yeah, one of the two should have been given. It's already discussed.
Yeah.
Go ahead.
So, ma'am, yeah, can we go ahead to the next case?
Yes.
Thank you, Dr. Manjusha. If there are any other questions in the chat box, we'll get back. But lovely diagnosis differentials that you had in mind and very well presented case. Thank you so much.
Thank you.
Well, you all know the younger generation of anesthesiologists are extremely conscious about preserving their environment, being economical and conserving resources while providing a safe anesthesia. So listen to our two youngsters butting their heads against using two such techniques for general anesthesia. Dr. Amulya Hande is a junior JR in Department of Anesthesia at Jupiter Hospital. He will be speaking in favor of total intravenous anesthesia. And Dr. Sneha Tiwari, a JR in the Department of Anesthesia at Jupiter Hospital, speaking in favor of low flow anesthesia with inhalational agents. Over to you, Amulya. We have 6 minutes for laying out your points, followed by a rebuttal. So you can take it.
Good evening, everyone.
Amulya, we can
Am I
see.
audible?
Yeah, and you are audible. You can start.
Yeah. So, good evening, everyone. Myself, Dr. Amulya Hande. I'm a first year DNB resident at Jupiter Hospital, Thane. So I would like to thank our guide, Dr. Sonali Sara, for giving us the opportunity to participate at this platform. So today my topic will be on total intravenous anesthesia. Yeah. So total intravenous anesthesia is a method of inducing and maintaining anesthesia using intravenous drug, avoiding the use of inhalation anesthesia. So as the use of inhalation technique is not always indicated or possible. So all the anesthetists should be aware and should be able to deliver TIVA completely and safely. So there are basic principle of inducing the patient with TIVA. The anesthetist should know the principle behind achieving and maintaining appropriate plasma and brain concentration of the intravenous agent which we are using. The anesthetist should know the factor determining the appropriate target drug concentration to aim for, and he should know how to adjust this when there is a light plane of anesthesia for the patient. And there are many monitors to and monitoring the patient receiving TIVA and various practical aspects ensuring that the intended dose of the drug is delivered to the patient. So our aim is to achieve a stable plasma concentration of the drug in the plasma and the brain.
Amulya,
Huh.
sorry
So
to interrupt.
normally,
Are you sharing the slide? Okay, great.
yeah, I'm sure. Yeah.
Yeah.
My slide is visible, no?
Yes.
Yeah. So every drug which we are using, so it undergoes distribution, metabolism, and elimination in a body. So there is a three compartment model V1, V2, V3. So V1 is the compartment, the drug which we administer, it get accumulated in the central compartment, which represents the initial value of the drug. And V2 and V3 are the peripheral compartment. So V2 is the compartment. So the drugs which are rapidly equilibrating, they goes in the V2 compartment, and the drug which slowly diffuse goes in a V3 compartment. And each compartment, when the drug moves from one compartment to another, each compartment has its own rate constant. And KE0, as you can see in the slide, the KE0 is the effector site. So the central compartment to the brain and the plasma. So for this pharmacokinetic model, so a mathematical model software is used to estimate these pharmacokinetic variable. And these pharmacokinetic variable, it occurs, we can use it under the influence of various patient characteristics like body weight, height, age, and sex of the patient. Yeah. So as an anesthetic, we can use a manual infusion pump or target control infusion pump to maintain the TIVA. So these are the components of TIVA. This slide shows various combinations which we can use while inducing a patient with total intravenous anesthesia. So we can use hypnotics, we can use opioids, ketamine, alpha-2 adrenoreceptor agonists like clonidine or dexmedetomidine. We can also use magnesium. So these drugs results in marked reduction of the required brain propofol concentration. So these drugs kindly add a synergy effect uh, between the drugs. So there occurs a synergy effect between, for example, between propofol and opioid. So it generally reduces the propofol dose required to produce the loss of consciousness. Even when remifentanil infusion is often used along with propofol infusion, the rapid offset of effect after stopping remifentanil. So this enables us to reduce the requirement of propofol by around 50% without causing respiratory depression. So at the end, I would like to discuss the advantages of TIVA. So it has improved hemodynamic stability in the patient. So we can use it in ASA grade 3 or grade 4 patient. It has a reduced post-operative uh, nausea, vomiting compared to inhalation agent, less airway irritation compared to inhalation agent. There is reduced risk of respiratory complication like respiratory depression and bronchospasm. Faster emergence of anesthesia post-surgery, no pollution or environmental impact. Eliminates the needs for scavenging system and better pain management with the help of opioid and other anesthetic agent. And it also has reduced risk of post-operative cognitive dysfunction. But whereas inhalation anesthesia shows its many disadvantages that it can cause airway irritation with the risk of coughing and bronchospasm, risk of awareness when the adequate MAC is not achieved. The inhalation agent also contribute to greenhouse emission and environmental pollution. It also contributes to the operating room pollution and hence posing a risk to the healthcare worker who are working in the OT. Emergence from anesthesia can be slower and may lead to agitation, and anesthesia depth control may be less precise. So this is a parent article showing the guidelines for safe practice of total intravenous anesthesia. Yeah. Thank you so much.
Sneha, you want to present your topic first?
Yes, ma'am.
Yeah.
Yes, ma'am.
Amulya, stop sharing.
Yeah.
My audio बंद कर दे. Is my slide visible?
Yes.
Yes. Good evening, everyone. My name is Dr. Sneha Tiwari, and I am a first-year junior resident at Jupiter Hospital, Thane. My topic is inhalation anesthesia with low fresh gas flow. So, inhalation anesthesia involves the use of anesthetic gases and vapors to induce and maintain anesthesia during surgical procedures. And use of fresh gas flow less than 1 liter per minute is called low flow inhalation anesthesia. A fresh gas flow less than 0.5 liters per minute is called minimal flow anesthesia. And fresh gas flow less than 0.35 liters per minute is called metabolic flow anesthesia. Inhalation anesthesia provides us with a predictable plane of anesthesia with help of MAC, which is minimum alveolar concentration, which is equivalent to EC50, the concentration at which 50% of the population will not respond to the surgical stimulus. And a MAC of 1.3 in almost all inhalation agents will give us an EC95. A basic prerequisite for the conduct of low flow anesthesia is the use of rebreathing systems. A fresh gas flow is fed into the system just enough to replace the gas absorbed by the patient, which gives us a closed rebreathing system or closed circuit. Some commonly used inhalation agents that we
Neha, please
use are
change your
classified
slides.
into volatile.
Please change your
Oh,
slide.
I'm sorry.
Okay.
Yeah. Yes. So one of the most commonly used inhalation agents are divided into volatile agents and non-volatile agents. Non-volatile agents only include nitrous oxide, which we use as adjunct for rapid induction and rapid onset and analgesia. And our volatile agents include the halogenated agents like isoflurane, sevoflurane, desflurane. Isoflurane being more cardiostable and potent. Sevoflurane has a pleasant smell and rapid induction, which can be used in pediatric population, reactive airways, including asthmatics. And desflurane has the fastest onset and recovery. Now, mechanism of action in short, it acts on central nervous system via modulating GABA receptors to produce sedation. It acts on our NMDA receptors to inhibit glutamate and provides us with analgesia and anesthesia. And it acts on potassium receptors and produces hyperpolarization in neurons. Now, administration of inhalation anesthesia is fairly simple. Low flow anesthesia requires a closed circuit. There is no requirement of any special training. All it requires is a vaporizer with our anesthesia gas monitoring, which is already a part of anesthesia gas machine. And it can be easily administered through an endotracheal tube or any supraglottic device. And monitoring can easily be done with capnography, pulse oximeter, ECG, and a BP apparatus. Now, advantage of low flow inhalational is that it improves our pulmonary dynamics of the inhalation gases. It increases the mucociliary clearance, solving the problem of our airway irritation. It helps in maintaining the body temperature and reduces the fluid loss. It has become fairly economical now to use inhalation agents, and it has reduced the costing up to 75%, and it has decreased the greenhouse emissions and lowered the impact right from ozone layer depletion to the OT pollution. Thank you.
I'm sure Amulya has a lot of questions for you, Sneha. Let's hear from Amulya.
Yeah.
Do you agree with everything she said?
No. Of course not. So
So
that was a
that was
nice
a nice
discussion by you,
discussion
Dr.
by you,
Sneha.
Dr. Sneha. But do you know
But do
the
you know
most
the most
highlighting and
highlighting and
deleterious
Your
deleterious
effect
voice is
of
effect of
echoing.
TIVA?
Echoing, lot of echo is there.
Lot of echoing.
Okay.
Yeah.
How about now?
No, you are okay.
So it was a
Yeah, better
yeah.
now. Better.
So it was a nice information given by you, Dr. Sneha. But the most highlighting and deleterious effect of inhalation anesthesia, which we all would agree, is its effect on the environment and the production of greenhouse gases. So according to the study, the healthcare contributes to about 4 to 10% of global greenhouse gas, out of which 63% of 40 greenhouse gases due to inhalation anesthesia. And 3% of entire carbon footprint is also due to inhalation anesthesia. Whereas the footprint of TIVA is almost negligible. So I think switching from inhalation anesthesia to TIVA can decrease the emission of up to 95%, which is an important step in achieving the goal of net zero carbon emission. So what do you think about?
Sneha, you are muted.
Okay. Hello?
Yep.
Yeah. So I think, Dr. Amuli, you're forgetting about the plastic, the disposable plastic that TIVA contributes to in our biomedical waste. According to WHO, the entire biomedical waste alone contributes, the plastic alone contributes to 30% of the waste, out of which the plastic syringes are 20% and IV tubings are around 5 to 10%. And about CO2 emissions and carbon footprint, so with the help of low flow anesthesia, we have somewhat come to a solution and which has reduced the CO2 emissions up to 90% and costing by up to 75%. Now, speaking of cost effectiveness, I think inhalation anesthesia will definitely get a point here, since TIVA patient has to pay for multiple medications, equipments, along with the overhead hospital charges. In inhalation anesthesia, patient has to pay for the agent, actually only the amount of agent that was used during the case. A vaporizer will cost around 4 to 5 lakhs. Whereas using TCI, a basic model alone costs around 6 lakhs. And if we go for any advanced TCI machines, it will cost around 12 to 15 lakhs. Infusion pump alone costs 20,000. And above this, IV tubing accessories, PMO lines, IV accesses, syringes, all these will cost to a patient around 500 to 1,000 of extra cost. So I think I get the point here, Dr. Amulya.
Do you agree, Amulya?
Ma'am, I think it's a good thing that she's considering the cost for the patient. But what about the post-operative cognitive dysfunction in patient of inhalation anesthesia? So a study was done, a review and meta-analysis on the same, which has shown that a pool incidence of post-operative cognitive dysfunction in TIVA patient was around 11%, whereas in patient in those inhalation anesthesia was used, it was around 27%. So which can be due to release of various cytokines.
You have anything to say for this, Sneha?
Yes, I think it is not fair that Dr. Amulya is just holding inhalational as culprit of POCD, whereas in his TIVA, there are drugs like propofol, which when used in high doses and continuous infusion, midazolam, morphine, benzodiazepines can also cause post-operative cognitive dysfunction. Post-operative cognitive dysfunction can easily be prevented by maintaining adequate depth of anesthesia, which is obviously more convenient with low-flow inhalation anesthesia than TIVA, with the help of MAC and anesthesia gas monitoring. A MAC of 1.3 to 1.5 actually reduces TNF alpha, IL-6 and IL-8 cytokines, which will decrease the POCD incidences. Apart from that, we can use neuromonitoring like BIS and entropy, which will also reduce the incidence of POCD. And I would like to add, the awareness control is much better in in inhalation anesthesia, because there is a lack of real-time monitoring of anesthetic blood concentration with TIVA. Awareness in TIVA is seen in around 19% of the patient, and not just that. Reported incidence of dreaming or near miss awareness is also associated with TIVA, which is associated with light plane of anesthesia, and it is seen in around 22% of the patient. So do you want to keep your patient in light plane of anesthesia, Dr. Amulya?
Of course not, of course not. The same monitor I can also use, like I can use BSAR entropy, which we are using to prevent the post-operative cognition. I can also use it to monitor the depth of anesthesia. But do you know, Sneha, that inhalation anesthesia are also known to cause airway irritation, and it has a considerable risk if you are using in a patient of respiratory disease. It can cause respiratory complication and bronchospasm. So we have to reconsider it if we are using it in a patient of acute respiratory tract infection like influenza or 3 years ago during the era of COVID-19. So as TIVA is far more advantageous than inhalation anesthesia as it avoids the deleterious effect of immune. So we are in inhalation anesthesia you using SIVO or isolated MAC 2.5. So it can suppress the main the cytokine, the TNF alpha or interleukin 1. So in TIVA, there is lack of any respiratory irritation, thus providing the edge on this current situation or of if we are inducing the patient of any respiratory tract infection or COVID-19 back ahead. Plus, many peripheral surgery can be done with the patient breathing spontaneously without any airway device. Thus, here we are avoiding any direct airway instrumentation. In short, we are decreasing the droplet and aerosol generation. So this can be safe who are working in that environment. So what do you think about this?
My dear colleague, low flow with closed circuit with vaporizer will decrease the airway irritation as it increases the mucociliary clearance, humidifies the air, and it will also prevent coughing due to irritation, which will solve your aerosol problem. And along with that, we can provide nebulization with agents like salbutamol and budesonide, which can significantly decrease the airway irritation in a patient and reduce the
But will you use inhalation anesthesia in a patient, or will you use muscle relaxant with inhalation anesthesia in a patient of myasthenia gravis, or if the patient is having history of malignant hypothermia? Will you use it?
See, malignant hyperthermia and myasthenia gravis are highly dependent on patient's genetics than it is on inhalation anesthesia. I think you spoke about use of TIVA in peripheries. So I would like to say that in peripheries, it will require some special training or different equipment. It has a certain learning curve that inhalation low flow anesthesia does not have. Use of monitoring, the monitoring and use of inhalation anesthesia is fairly simple. The trigger alarms are inculcated in ventilator itself, and the ventilator will also report the amount of drug concentration in exhaled air and the actual effect size of drug in the patient's circulation.
But Dr. Sneha, one experienced anesthetist is also capable of doing TIVA cases without any infusion pump. If he knows the number of, if he knows to calculate the number of drops, if he is using the drops at infusion, he can deliver the adequate drug which is required to maintain the plasma concentration. So the
Amulya, you are muted. Yeah. Yeah, we can.
So experienced anesthetist, he can deliver TIVA even without using infusion pumps. If he knows the number, if he knows to calculate the number of drops, he can adjust the dosing for the patient, and he can even maintain the plasma concentration which is required.
Do you have anything to add, Sneha? You're muted.
As I said, monitoring, if we are using TIVA in periphery, it will require the entire team to be alert. It will require a separate set of monitoring. And whereas that is not the case with inhalation anesthesia. So the patient, the staff will not will be focus on equipment, or the staff will focus on monitoring. That will be the case. So in the end, we would like to summarize that there's I would like to share my screen again and show you a scale that was published in a systemic review and meta-analysis in May 2024 after some randomized trials. And it showed the mortality and morbidity in patients, a comparison of mortality and morbidity in patients when TIVA and inhalation was used. So we can see that it's fairly similar. In other cases like PONV, emergence delirium, major bleeding, surgical site infections, TIVA gets the point. And while maintaining the patient's awareness, inhalation anesthesia proved to be more convenient. The concept of sustainable development includes three concepts: people, profit, and planet. If we talk about the people, that is the patients, as we saw, the mortality and morbidity is fairly similar in both cases. So we can use either of the one depending on the comfort of the healthcare worker. And speaking about planet, so I think I have to agree, TIVA is more ecological. And but speaking of profit, I would like to appreciate inhalation anesthesia as it is more cost efficient than TIVA. So do you have any take-home point for TIVA?
Yeah, so my take-home points for TIVA, yeah, anesthetist should be trained and competent enough to deliver TIVA even in the periphery. In our department, it is preferable to stock only one concentration of drug, or example, propofol, and only one concentration we can dilute remifentanil. Like we have to keep a standardized concentration which can be used for all the cases. The infusion sets which we are using should have a lever lock connector at each end. So there are less chance of getting the line getting disconnected and wasted of the drug. And in short, we can prevent the light pain of anesthesia. The infusion set should also have an anti-siphon valve on the drug delivery line. It should also have an anti-reflux valve for fluid administration. And the drug and fluid line should join as close to the patient so that we can minimize the dead space. The infusion pumps which we are using, it should be programmed before the syringe has been attached. It should be programmed only after the syringe has been attached to the pump. And we have to make sure the pump is fully charged and the infusion pump should have a charging port. The IV cannula or the central venous cannula through which the infusion is delivered should be visible throughout the procedure. So these were my take-home points for TIVA. Thank you so much.
Now speaking of low flow inhalation anesthesia,
Neha,
so
your
with
voice is echoing. Echo.
okay. So low flow anesthesia has become a cornerstone of modern anesthesia practice due to its efficacy, easy controllability, and versatility in various surgical settings. But it is absolutely advisable that we should remember that when we use inhalation anesthesia in periphery, it should be with a closed circuit and low flow, and we will be able to benefit it the most. Thank you so much. Thank you so much, Sonali ma'am, for the opportunity.
Yeah. So I will open this discussion to Sir and Kane Madam. You can you can you can quiz them on their articles chosen and the way they present it too.
So, Sneha, you and Amulya, your presentations were very good. You are good debaters. You had very good points in favor of whatever you were saying. Now
you.
we have to play for both of you. So, Sneha, you have said it is very cost effective. You know the anesthesia workstation cost. Can you do it in a peripheral hospital, low flow? Besides that, your ETCO2s, your working ETCO2s, your end-tidal anesthesia gas agents, everything have to be proper. You have to be well educated to use low flows. Yeah, at least if you want to use even 1 liter, like you have to be really educated for this. We cannot have any hypoxia, hypercarbia for given to the patient, isn't it? So that's very important. And what you said that people, planet, and profit, these 3 points have to be taken into consideration. That's a very important point you said, because desflurane like will remain in the, how much does it remain in the atmosphere? Say 14 years, nitrous 114 years. So nitrous is nearly banned. So we know all these things. Then there are global warming potential and all these environmental factors. You have nicely told about everything. But when it comes to a patient, like if you have an obese patient, a people factor, if you have an obese patient, I would like to use desflurane in spite of knowing what it does to the environment. I would prefer it over a propofol maybe. So, and to play very safe, I use a combination of both. So finally, when it comes to patient, you have to take all the patient things into consideration, all the comorbidities in the patient. He brought up that point about malignant hyperpyrexia. Would you use inhalational agents? So whatever may be the advantage, there you will go for TIVA, isn't it? Then you talked about TIVA and all the plastics that contribute to the pollution. Yes, I don't think we get away with pollution anyway. Anything that you use, we are contributing to the pollution in some way, whether it is the plastics, whether it is the even vaporizer is an electronic waste which is going. Same way a pump. And which infusion pump do you get for 20,000 rupees? I don't know of any infusion pump. You said 20,000, you get infusion pump. I don't think so. 20,000 is too little of money to get a infusion pump. And yeah, so I think you have covered up most of the points. So finally, as a clinician, you put all the three together, the people, the planet, and the profit, and make your own protocols for your cases. And your resources are very important. What is available to you? That is very important. And how much knowledge you have about use of that. So that is also important. So knowledge, a practical, theoretical background with a practical approach is finally your and your experience. That is finally what you're going to do. Dr. Bapat, you please
Yes,
come
ma'am.
Yeah, Dr. Kane has summed up it so well. But first of all, I must congratulate both of you for a presentation, keeping in mind that you are first year residents. And I don't know, as a first year resident, whether we are so knowledgeable and so bold to share the views and present. So, congratulations to Dr. Sonali Saraf for preparing these two young minds and young guns. Anyway, coming back to the summary, you said the planet, profit, and planning. I think the most important for us as an anesthetist is the patient and the patient safety. And patient safety is the mantra of the new age. A world has moved now not to deliver what is evidence based. That era has gone. And now the world is saying that you should provide the patient what patient wants and rather than what you think or what your evidence says. All said and done about the low flow anesthesia and TIVA, both have learning curves. Both require the anesthetist needs to get trained in the both the techniques. It's not that the low flow anesthesia is very easy or Dr. Amulya, the TIVA is very easy. As you rightly said, you can have the gravity fed infusions and you can calculate the drops and everything. Yes, anesthesia is a science and art. I agree with you. But there is something called technology assistance, and that is going to going to stay with us today and in future. As far as costing is concerned, mind you, no one takes into consideration the indirect cost. Now, indirect cost, what I mean is like when you said environment about TIVA and everything, you have to take into consideration all the industries who produce these electronic pumps, how much expenditure and how much carbon dioxide footprint they have in the world, and that they should sum up. And you cannot just call as a biomedical waste of plastic that is the contribution of TIVA. That's wrong. The same holds true for inhalation anesthesia. Not only the inhalation gases which are getting exhausted or scavenged at active end or passively or whatever it may be, it's the, as Madam said, it's a electronic circuit, the electronic vaporizer, and whatever the things which are going to go as a e-waste. That also goes in a long way. And most important thing, as you rightly said, I still recollect one. There is one beautiful editorial by author called Gray and Nunn. Maybe you people don't read those old books now because you have the Google Guru at your hand. When the muscle relaxants were developed, he has a fantastic editorial who said that I'm afraid that the next generation of the anesthetists will paralyze the patients more and will forget how to give anesthesia. And the greatest danger in TIVA is that you are paralyzing the patient sometimes or most of the times, and you are playing with the TCI without knowing the effect, the effect site concentrations. You also presume depending upon the software models like Everard or the Kataria or pediatric models, which are the research protocols, but you really do not know. And on one hand, does it come to your ever in mind that you are always taught how to take care of the sympathetic control? So you are blocking the efferent arm, you are using beta blockers, you are using dexmedetomidine. So you don't know what is happening to the patient because the changes which are going to happen in the pulse and blood pressure and are going to not happen because of your own drugs. And how do you say what is the depth of anesthesia unless you have a BIS monitor or the
Monitoring.
auditory work potential monitor who will spell out the depth. So depth of anesthesia and awareness is a big problem in our TCI, okay, that we must accept. And so also the difficulty and how to use the low flow technique. Low flow technique is not a technique of dialing or changing the concentration dials. It is a specific methodology, how you can give bolus inhalation, how you can induce with inhalation, and how to maintain then with a low flow technique. But both of you have done a brilliant job of putting both the views across. I think ultimately it comes to the judicious decision of an anesthetist. He must understand what he's trained into, what is the best for the patient. Is the patient pediatric? Is the patient obese? Am I going to look at the lines? The intravenous lines, you may say you need a dedicated line, but in a pediatric child, 1 year, 2 year old, which completely full drape, you may not have access to the venous access once you start the surgery. Yeah. So also in the obese patients. So you have to justify and tailor make your anesthetic management and use judiciously either of the technique. Each one has its pros and cons, but which is best for that patient, and the patient comes as a priority. Profits and planning, of course, go a long way. And I think you have summed up very well. Yeah.
Yeah, one more comment. When this Marsh and Snyder, which we commonly use in TCI pumps, when the research went on, it was on ASA 1 and 2 patients. They never included obese patients. They never included elderly patients. They never included patients with liver problems or kidney problems. So it was ASA 1 and 2. And the setting is done for ASA 1 and 2 patients. So it's going to give as per that setting, isn't it? So it will never be perfect for other cases. So that's very important. Now the Evelet, the newer one is more broader and it can be used for many more patients. But the cost is much more again. So it's a lot of factors. And as you rightly said, it is the people, the planet and the profit that you take into consideration. Everything has to be taken. But a brilliant discussion by both of you. Very nice.
Thank you.
Thank you so much, Deepa Gane madam and Bapat sir, for this valuable feedback. I can understand both of them are in their scrub still, so they have a lot of work to do still. So we will conclude here saying here's to practicing safe, economical and environment safe anesthesia and to continued learning. Thank you so much. Back to Manisha, Nilima.
Yeah, Nilima.
Hello.
Yeah, we can hear you, Nilima.
Yeah. Hello.
Yes, Nilima, we can hear you, but we cannot see you.
I don't know, my video is not getting on. Yeah.
Yeah.
So, wonderful evening. Thank you, Thane ISA office bearers, Dr. Manisha Ghosh, Dr. Karna Thakkar, and our founder president, Dr. Sunil Katkade sir, for this wonderful webinar. Thank you, SAM's office bearers. Thank you so much, our chairpersons for today, Dr. Deepa Kane and Dr. Jitendra Bapat. We are very fortunate to have these two stalwarts today, and we would like to associate with them again in future. Thank you so much, Dr. Sonali Saraf, for moderating the session seamlessly, especially the debate. Thank you all the speakers, Dr. Nivedita, Dr. Manjusha, Dr. Sneha, and Dr. Amulya for very nice presentations. Thank you, Mr. Ganesh and Jeneka Technologies for providing online platform without any technical glitches. And thank you all the delegates for attending in large number. It gives us encouragement to conduct such webinars regularly. Thank you so much. Manisha, should we conclude?
Yeah, and thank you to you, Nilima, for taking all the efforts for putting this webinar together. And it was very enjoyable. So now we can start planning our next one, and I hope Madam and Sir will join us again very soon in the
Sure.
future.
Thank
We'll be
you, ISA
spectators
Thana.
and we'll be spectators, so don't worry. Yeah, and thank you. Thank you.
Just one last comment that in NAP4 study, it was said that incidence of awareness is more in TIVA technique, and also the propofol which is left over, it is discarded in the water, running water, or in rivers and all. So there was one study where they had found that it is very, very toxic to the aquatic animals, and also it led to infertility in some of the fishes. So that's just one point.
Yeah, the traces of all these drugs come back to us also, na? Not only
Yes.
to aquatic animals. It all
Yeah.
comes back to us also. In
Yeah.
micro.
Yeah, but there the concentration is higher in the water. When it comes back to us, that time again it will be lesser. But
Yeah, the greenhouse effect and the environmental impact it itself is a topic and can be a fantastic webinar, because there is so much of propaganda against and for both, and no one really looks into the real integrities of how they calculate global warming potential, whether it is appropriate tool to comment the hazards what we are as a community, as an anesthesia community, how much we are contributing. If you see the aviation industry, now you buy an Indigo ticket and it will tell you how many carbon dioxide footprint it is having and how many kilos they are saving. But if you see as a consensus anesthetist that I'm not going to use Desperin tomorrow, do I travel from here to Delhi on foot, or do I buy a ticket and board on plane? So when it comes to the practice, there is a lot of ambiguities as an individual also, because we always follow what is easy way. Every time you are not that conscious. So sometimes, as I said, patient comes a priority. If my patient is in hepatic failure, renal failure, I will be using the best molecule in the world, and that's a Desperin as of today. I may be contributing 0.002% of whatever that carbon footprint, but for my patient, that's a safety. And the cost is an economic word, actually, a commerce word. What you are calculating a cost from the expenditure point of view, what it can cost the patient. If patient gets awareness, patient is himself is going to go into a post-traumatic disorder or something, and even he can sue you. So the indirect cost what you are going to bear of causing awareness inadvertently is very high. So cost is not just a price tag or MRP which is printed on the drug or the instrument or something like that. The indirect costs which are involved are very, very high, and where we can't neglect them. Yeah.
absolutely, very well said. Yes,
Everything has to be customized as per the need of the patient.
exactly. Yeah, yeah.
There's
Okay.
a fantastic editorial by Atul Gawande, the last WHO oration what he had, where he said that our practice of medicine has to get shifted from evidence-based medicine to the patient-centered medicine. What patient wants, because what you are offering evidence-based may not be what he desires. He says, "The hell with you! I don't want this. I want this." And then, as a provider, we should provide what patient wants in his life, because ultimately the quality of life what he's going to have post-operatively or whatever, he's going to decide what is good for him. So it's a fantastic lecture. You people have the access, please read and listen to it. Yeah.
And also among all the inhalational anesthetics, nitrous oxide contributes much more than the inhalational agents. So that also should be kept in mind. And there was one very nice article in which they compared the greenhouse effect of the vehicles compared to our anesthetic agents, and they had shown like two towers of 120 stories. So the emission caused by the vehicles was compared as 120-story building, and what anesthetics contributed was around 2 or 3 storied small building.
That's what
So
I'm saying. That's what I'm saying. If you see the carbon footprint, the agricultural nations like India and China are the maximum producers, because we are agricultural country. Now, are you going to stop the agricultural the procedures and processes? It's a very, very complicated and multifaceted things which are not been addressed properly by the anesthesia. There's so much of a hue and cry about the inhalation anesthesia causing global warming and so on and so forth, and global warming potential. There's one fantastic article which even I forgot just now. Otherwise, I would have shared, and maybe in future I can share with you people inside about who has looked into these intricacies of processes. Yeah.
It is also saying, some fertilizers cause congenital anomalies in children. They're producing congenitally abnormal kids because of certain fertilizers. So there's so many things which is causing a lot of problems, which is affecting our environment. So I think government needs to look at many more things.
Also, there's one very interesting thing where, because of scavenging system, now the inhalational agents are again recanned and reused.
Yes, reuse
That
also.
also, yes.
Reuse.
That
Many
lacks
research is
cost.
going on about
Yeah.
that, about the reusability of the
Yeah.
agents.
Yeah, but they've already started it. So from these scavenging gases. So those canisters, those are different vaporizers which have the reused gases, but that is half the cost of the inhalational agent that we get in the bottle. So yeah, very nice, interesting webinar. Yes.
Good night, everyone. Yeah.
Yeah,
Thank you,
thank
sir.
you all.
Thank
Thank
you,
you.
ma'am.
Bye.
Thank you, everybody.
Thank you.
Great
Thank
webinar.
Thank you.
Thank you,
Yeah.
Ganesh. You
Yeah.
can
Thank you all.
close now.
Thank you. Good night.
Bye
Thank you.
bye. Bye.
Thank you, Dr. Sonali. Bye.
Bye, Deepa Kane
Thank
madam.
you. Excellent
Bye.
webinar. Thank you.
Bye. Bye.
Bye.
See you.
Katkade sir, hello and bye.
Sir is on mute. The Krishna Joshi sir is also there.
Oh, hello,
He-
sir.
He
Hello,
was
sir.
Joshi sir.
he was listening very carefully, I suppose. Now he is unmuted. Sir, what are our
Yeah, and it's an excellent effort by all, and I must compliment the whole team for encouraging younger lot to come up and speak.
Yeah,
That's most important. I thought,
yeah,
and they had prepared it very well.
very well.
Thanks to direction by Sonali.
Dr.
Whosoever it is,
Sonali.
they did very well on their own, and that's the
Yeah.
best way to promote them to come out and study more academically. Very nice effort. Thank you all. Very good.
And the first year especially, that
Yeah,
was
Exactly,
first year.
definitely,
Bapat
definitely.
said. First
Very
year
true,
to
very
put up
true.
a show like this is very good.
No,
So
ma'am, this
Manisha,
was a very good
Nilima, all of
exercise.
you,
They sat
Manisha,
down with
Nilima, Sonali, superb.
pencil
Very good
and
effort.
paper
Yeah.
to find out the cost of everything. That was
Good.
the
Very
best.
good, very
But
good.
madam,
Good.
infusion pumps are available at 20,000 now, huh?
Which
The
quality?
simple
Yeah.
ones. Yeah,
Quality
not
kya
the
hai?
very simple
Not
ones.
TCI. Not
Inmed,
TCI
Yeah, of
one.
course, but they are there at
Inmed,
Not
Inmed.
TCI one.
No,
Infusion
no,
pump,
com-
yes, but not
and
TCI.
compliments,
no,
and also
definitely.
compliments to Jitu as well as Dr. Kane for excellent cover up of the entire procedure. Thank you very well. Very good
Thank
comments
you,
by
sir.
both of them. Very good.
Thank you.
Thank you.
Thank you, sir.
Absolutely. Yeah.
Okay,
Thank you,
good night.
Good
madam
night,
and
everybody. Good night.
Dr.
Good night.
Vapad for
Bye.
joining.
Good night.
Thank
Good
you.
night.
Good night.
Bye.
Bye.
Thank you. Good night.
Good night. Thank you. Thank you.
Hello, may I take one opportunity to brief all of you that I have shared with you one workshop on 18th of August on the researcher and screening of the literature search, and that's a fantastic one. The Sumati, she's our ex-librarian and she conducts that so well. It's not only dictating type of workshop, and all the juniors, I think, first year, second year, third year, and if they register for the conference, it's free, which will be in the again share the flyer, and if they just want to attend that course also they can enroll for that, and I'm 100% sure if they are in the first year resident they will be immensely benefited by that workshop. It is called as a young researcher, but it starts from the basics, how to do the literature search from the PubMed, all the methods and everything. She's brilliant uh, person to conduct that workshop. Yeah, so
Yeah, she's
just
very
encourage.
good. I
Yeah,
heard
just
her at KEM once.
So
Yeah.
this
just
is the MASCON workshop you're talking
yeah,
about?
it's a
Yeah,
MASCON workshop.
I got it.
So so you will see the flyers again on
Yeah, I've seen it.
Yuva Mahakon
Yeah.
also. But you need to register online, and if you are already registered for conference, it's free. But
Yeah.
you need to register because we want to know how many
How many are
total delegates, because it's a half days of hands-on. They will come with their own laptop, and she will teach everyone how to search for the clinical research question in your mind. So if your junior is designing some paper, designing some thesis topic, or how to search whether it is really doing work. If it is there, then what is the literature search? And it's brilliant. I am myself looking forward as a coordinator to learn from her once again. I learned 10 years ago down the line, and down the line she has evolved, and she shares more and more platforms. She's going to share one more software also, which is used for bibliography, because bibliography is a big headache for the mentors also and for the kids also. I think everyone will agree. So I'm really requesting all of you to, in your own institutes or something, just spread a word. Whoever can attend, I'm 100% sure they will go a long way. Yeah.
Thank you, sir.
Bye bye.
Bye-bye.
Thank you. Bye. Good night.
Night.
Bye. Bye.
Bye, Parna.
Bye. 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 Sir.
Thank
Bye,
you, Dr. Katkade. Bye.
Bye. Bye.
Madam, meeting in the room. Hello.
Thank you, Ganesh.
लॉग आउट करू शकते गणेश.
Yes, yes. Okay, madam.
Thank you very
करतो.
much, Ganesh. Thank you.
Welcome, madam.
Bye. Bye. Bye.